All right. Good afternoon, everybody. This is Hossein Maimani. Today, I have my partner, Dr. Mark Barnett, works here in the Longmont office with me at Rocky Mountain Cancer Center. And today, Dr. Barnett is going to be presenting some research updates in the field of prostate cancer. As you guys are aware, this month is Prostate Cancer Awareness Month, and Dr. Barnett has really carved out a niche for himself in the treatment of genitourinary cancers here in the state of Colorado. He, just as an introduction, grew up in Illinois. He did his medical school training in Illinois and then did residency and fellowship at Brown University in Rhode Island. He has been here with Rocky Mountain Cancer Center in Longmont since 2006 and has been really the center for our development of our Longmont office here since then, and was one of the main reasons why I joined Rocky Mountain Cancer Center, mostly to work with Mark. So I will go ahead and hand it off to you, Mark.
All right, thank you, Hossein. So today I'd like to discuss the topic of metastatic prostate cancer and more specifically present some of the highlights from this year's American Society of Clinical Oncology Conference. First, though, before discussing, hold on one second. Oh, there we go. Can you see me, Hossein?
I can. I think we were doing okay with the share screen.
Okay, so you can see it there?
Not right now, but we had it right before.
Okay, all right. Let me see what I've done here.
We're all learning Zoom.
Yeah, especially me. All right. Okay.
That's good.
All right. Let's see. Okay. All right, now it's working. Before talking about some of the highlights of ASCO, I wanted to give a brief overview of metastatic prostate cancer, and specifically to talk about androgens, specifically testosterone and the androgen receptor, because most of our prostate cancer treatments center around this axis. So in its early phases, metastatic prostate cancer is primarily a testosterone-dependent disease. And historically, most of our treatments have centered around either lowering testosterone or blocking the effect of testosterone. And those treatments can often hold the disease in check for many, many years. And what this slide demonstrates on the left is that traditional pathway. Testosterone is converted to dihydrotestosterone by an enzyme called 5-alpha reductase. That byproduct binds to the androgen receptor, and it's that binding that really stimulates the tumor, increases tumor growth, extends tumor survival, increases proliferation. And that works often for years. The difficulty with this treatment is there are often a lot of long-term side effects and toxicities, and we'll talk about those as we look at some of the abstracts from ASCO. And probably the bigger challenge is ultimately prostate cancer develops what we call androgen independence, meaning that the cancer develops the ability to grow in the absence of testosterone signaling. And that happens for a variety of mechanisms. The androgen receptor often becomes amplified over time, so the cancer cell can be stimulated with smaller amounts of testosterone. The cancer cell can sometimes develop the ability to produce its own androgens, and there can be mutations in the androgen receptor that allow the cancer cell to grow despite the signal from testosterone. So historically, that was a big problem. And over the last decade, we have developed a new class of therapies which have played a key role in the treatment of patients with metastatic prostate cancer, and we broadly term these anti-androgen therapies. So historically, what we had was essentially suppression of testosterone. These have broadened the treatment options for patients. We generally look at these drugs in two broad categories. The first are the 5-alpha reductase inhibitors. These are shown on this slide at the top. The most commonly used is a drug called abiraterone or Zytiga, which blocks the conversion of testosterone to dihydrotestosterone. And the second class of drugs we broadly call androgen receptor blockers. And those essentially block the ability of dihydrotestosterone to bind to the androgen receptor. And those have really augmented what we can do with traditional Lupron and androgen deprivation therapy, and they have clearly improved outcomes for patients with metastatic prostate cancer. So historically, before the development of new therapies, there was a fairly basic prostate cancer treatment paradigm. Patients were diagnosed with metastatic prostate cancer. They were treated with androgen deprivation therapy, medicines that basically lowered testosterone production. That therapy often controlled the disease, sometimes for years, but ultimately what happened is, as we discussed, patients would develop resistance to androgen deprivation therapy, and they developed hormone refractory disease. That was a real problem. Historically, we gave chemotherapy in that situation, and over the last many years, the chemotherapy regimens developed for prostate cancer have become much more effective. So with the rise of more effective chemotherapy and with the rise of the anti-androgen therapies, that treatment paradigm really flipped. So doctors began to wonder, well, what would happen if we took our more effective therapies and gave them earlier in the course of the disease? That has been studied in multiple trials. And the paradigm really is now to give traditional androgen deprivation therapy up front in the majority of patients with either concurrent chemotherapy or one of the new concurrent anti-androgens. And that paradigm change has resulted in significant improvement in outcomes over the last 5 years, especially. This slide looks at the evolving landscape in prostate cancer as of 2020. And I would just kind of draw your attention to the middle column on this slide, which looks specifically at newly diagnosed hormone-sensitive prostate cancer. Probably the biggest change in how we treat this disease came about in 2015 with the publication of a study called the CHARTED trial, published in the New England Journal of Medicine. It was a trial of nearly 800 patients. And that trial looked at adding one of the newer chemotherapy agents, docetaxel, to androgen deprivation therapy right off the bat, right from the beginning, and compared that to doing androgen deprivation therapy alone. And that trial had a pretty dramatic result. The survival for patients treated with both chemotherapy and testosterone suppression was over a year longer than patients who got testosterone suppression alone. Shortly after that trial, the results were confirmed with a large study out of the United Kingdom called the STAMPEDE trial. The STAMPEDE study is actually a very interesting study. The British health system has had this study going on for many years. There are multiple arms of therapy, and it basically looks at different treatment options and novel treatments for patients with advanced prostate cancer. And we've actually gotten quite a bit of helpful information from the STAMPEDE trials. So the first STAMPEDE publication confirmed a significant advantage to docetaxel chemotherapy, confirming the results of the CHARTED trial. And then in 2017, in the Lancet, it was published that one of the newer anti-androgens, abiraterone, got similar results with a significant extension in survival when added to androgen deprivation therapy. The results were similar to those seen with chemotherapy, and multiple trials followed on its heels. You can see them listed in that column, looking at some of the androgen receptor blockers. So over the last 5 years, we've really seen a significant improvement in the treatments and the number of treatments that we can offer for patients. So that really kind of sets the background. That's where we are right now. Treatment options have really accelerated for patients and are changing. And what I'd like to do is highlight 3 trials presented at ASCO this year, specifically dealing with metastatic prostate cancer. So this is where we're hopefully going. The first trial is the CONDOR study, which was a study that looked at the utility of a new type of targeted PET scan, one that targets PSMA, or prostate-specific membrane antigen, to look for occult metastatic disease. The second trial is the one I'm probably most excited about, the therapy trial, which was a phase 2 study looking at a small molecule, radiolabeled small molecule, that targets the PSMA receptor. And this is a very highly anticipated therapy, and this was the first direct comparison of this therapy to standard treatment, so a highly anticipated trial. And then finally, the HERO study, which got a lot of discussion at ASCO, which looks at a new novel form of androgen deprivation therapy, an oral GnRH antagonist, relugolix, comparing it to the traditional therapy of GnRH agonist Lupron. And when we discuss the HERO trial, we'll talk about the differences between the two. So first, the CONDOR study. So given that our treatments for metastatic cancer, or for metastatic prostate cancer, have improved significantly, it becomes very important to know whether or not a patient actually has metastatic disease. And there's been general agreement that our traditional imaging modalities, CAT scan, bone scan, the things we typically use in patients to try to find disease that has spread, really are not up to the task. So the CONDOR study was a study designed to look really at the specificity of a new type of imaging, basically a PET scan that uses a radiolabeled sugar that targets the prostate-specific membrane antigen. So there have been several trials looking at this new imaging modality that have clearly demonstrated that it appears to be much more sensitive in its ability to pick up metastatic disease than our current imaging modalities. And this study really looked to see if we can trust those results. How specific is it? So essentially, this was a trial of roughly 200 patients who had biochemical relapse. So these were patients who had been treated with either a prostatectomy or radiation with the idea of curative treatment, and had then relapsed and had a rising PSA. So this is unfortunately a common clinical challenge. It becomes often very difficult to determine whether these patients have metastatic disease or do not. And for all of the reasons that we've discussed, it becomes increasingly important to answer this question correctly. So essentially, the treating physicians in the trial were asked to complete a questionnaire talking about how they plan to manage the patients. The patients were screened with traditional imaging modalities, usually either CT scan or bone scan. All of the patients had no evidence of metastatic disease on those traditional studies. Those patients then had the new PET imaging study. The results were given to the treating provider, who then reviewed them and completed a post PET questionnaire saying how they plan to manage the patient now. In other words, was there a difference between before the scan and after the scan? And more importantly, in those patients who had a lesion detected, that lesion required confirmation of some site, of some sort. And the trial designed an endpoint called the correct localization rate in an attempt to show that if there is truly a result on this more sensitive test, that we can trust that result. And so clinical confirmation was done either by direct biopsy or by conventional imaging, where they used either MRI, CT scan, or bone scan targeting the area of concern, or if neither of those were done and the lesion in question received radiation, it was expected that the PSA should drop by 50% by 3 months. And so those criteria were used to create this correct localization rate. All of the images and data were reviewed by 3 independent radiologists. And what was remarkable is there was very uniform consistency across all 3 independent reviewers. You can see that in this slide. On average, the correct localization rate, which was the main endpoint of the study, was met on an average of 86% of the scans. So very high specificity, frankly, higher than the study designers had expected. So this was a very exciting trial. The things that I think are quite interesting on this study, the median PSA value was 0.8. The reason that's important is that at PSA values of less than 1, traditionally it's been very difficult to get accurate imaging. And so this was a study where the majority of patients had a very low PSA level, and the accuracy was actually still maintained and was quite high. What was maybe more remarkable was that in this patient population that was heavily screened, so remember these were 200 patients who had received traditional scans, CAT scan and bone scan, and had no evidence of disease on these scans, 60% of those patients were found to have a lesion on the PSMA PET scan. So 60% of the patients were found to have something that was missed on the other scans, and there was an 85% accuracy rate. What's more remarkable to me is that 50% of the patients had a PSA of less than 1, and the accuracy rate at those low PSA levels was 75%. And what's potentially more surprising is at the very low PSA range of less than 0.5, the accuracy rate was 73%, which was remarkable accuracy at a very low level of PSA, meaning that if you found a lesion with a low PSA reading, you could trust that it was a true lesion. 64% of the patients going into the trial ended up having a change in their management. So what this tells us is this is an imaging modality that has a tremendous potential to really affect patient care and really potentially expands our ability to find metastatic disease. And if we decide a patient doesn't have metastatic disease, to be confident that that statement is true. So PSMA PET scanning is really hopefully an imaging study that will be available in the very near future. There have been multiple other trials looking at this imaging modality, and what those trials have shown is detection rates. Basically, the sensitivity of this imaging modality is much higher than the next best thing that we have now, which is the F18 fluticasone or albumin PET scan, which can detect a lesion in patients with a PSA less than 1, somewhere between 20 to 40% of the time. The newer PSMA scans can detect lesions at these low PSA levels nearly at a rate that's almost double, roughly 44 to 61% of the time. And what the Condor study showed is we knew these were sensitive tests, but they're specific. We can trust them. So, the cautionary statements, we don't really know what the right strategy is to use this modality. It's an exciting modality that we hope to have available very soon, but it is not yet FDA approved. It is hoped that studies like Condor will lead to the FDA approval of this technology in the very near future. So the next trial is the one that I'm perhaps most excited about, the therapy trial. This was highly anticipated. A therapy trial was a study of a radio-labeled small molecule. So essentially, a radioactive particle, lutetium PSMA, lutetium is attached to the ligand for the prostate-specific membrane antigen receptor. So the ligand is basically what binds to the receptor. So that's designed in a lab. And then this radioactive lutetium particle is attached to it. This is given intravenously, usually every 6 weeks in the outpatient setting. Basically what happens is when the ligand binds to the PSMA receptor, there are beta particles emitted by the lutetium radioactive particle that result in death of the prostate cancer cell. So the early data on this treatment modality has been very promising. This represents an extremely exciting and completely new way to treat prostate cancer. And the importance of the therapy trial is this was really the first study that compared this new treatment to standard treatments that are currently available. So this was a really highly anticipated trial. So it was a study, again, of roughly 200 patients. These were patients that had received quite a bit of treatment. The criteria to get into the trial is these were patients who had had progression, meaning the disease grew after standard chemotherapy, docetaxel. The patients had to have a PSA of greater than 20, which is a fairly high PSA level. And most importantly, the patients in the trial were screened with 2 different types of PET scanning. So kind of getting back to the idea that we're sort of evolving the way we look for metastatic disease. In this study, a different type of PSMA scan called a gallium PSMA scan was done. And then patients had the standard F18 PET scan, the FDG PET scan, the most commonly used. And the reason that was done is the study coordinators wanted to make sure that there were no lesions in patients, sites of disease in patients that weren't identified by the PSMA scan. And that was important because the treatment targets that PSMA receptor. And if there was a lesion in a patient which didn't express that receptor, it would be inferior care to give them a treatment modality that only targeted that receptor. So it was a fairly rigid trial in terms of screening criteria. Patients were then randomized to get the new treatment, the lutetium PSMA, or cabazitaxel, which is a second-line chemotherapy that is generally effective in patients who've had progression on standard chemotherapy. It was a one-to-one randomization. So patients were randomly assigned to one of the 2 groups. A total of 300 patients were registered in the trial. The majority who were excluded because they had what's called FDG discordant disease, meaning that the second type of PET scan picked up a lesion that wasn't identified on the PSMA scan. Randomized to the 2 groups, one of the criticisms was the treatment group, the control arm, the cabazitaxel, the group that got chemotherapy. The arms were a little imbalanced because patients who were randomized to the control arm were allowed the option of withdrawing consent to the study, and so that led to a little bit of a imbalance between the arms, but it was not thought to affect the accuracy of the study. And so the outcome that the authors were looking for was a PSA response of greater than 50%. So essentially looking at where the PSA was when the patient started treatment and then what happened to that PSA after treatment. The median follow-up in the trial was a little over 1 year, 13 months. And as you can see from this waterfall plot, there was a pretty dramatic difference between the 2 arms. The patients getting the lutetium PSMA, the small molecule, had a 66%, or 66% of the patients, 2/3 of the patients, had a greater than 50% drop in their PSA level, as opposed to a little over 1/3 of the patients on the chemotherapy arm. So it was a more effective treatment, but I think what was equally surprising is it was also a much less toxic treatment. So this is the what we call the adverse events, so the side effects of the treatment. And what this slide specifically focuses on are the grade 3 and 4 side effects, the things that really make people sick. And what it was also clear in the study is the grade 3 and 4 adverse events, the toxicities were much greater in the chemotherapy arm, cabazitaxel, as opposed to the new small molecule lutetium PSMA. So 54 grade 3/4 adverse events with the control arm, as opposed to 35 in the experimental arm, big difference. And of those adverse events, the major 2 events were thrombocytopenia, which means a low platelet count, and then a dry mouth. And the reason the dry mouth occurred is that the PSMA receptor is expressed in very low levels in parotid and salivary tissue. So what was remarkable about this new therapy is not only was it more effective, but it was also a lot less toxic than chemotherapy. So very exciting potential new treatment for patients with metastatic prostate cancer. This was a very anticipated trial. This was the first randomized trial looking at this specific treatment. This was a heavily pretreated patient population, and I think the surprise was it had a very high response rate with a lot less toxicity than traditional therapy. Again, the main toxicities appear to be a low platelet count and a dry mouth because of the expression of PSMA in the salivary glands. So the big question we all have is, when will this potentially be FDA approved? When will we potentially be able to give this to our patients? We don't know, is the short answer. It's not currently FDA approved. There is a large multinational phase 3 trial called the VISION trial that is currently underway. It's closed to accrual, meaning that all of the patients that they plan to evaluate are already on the study, and it's estimated to be completed in September of next year. So we hope that within a year's time, we have these results confirmed in a much larger study, and that maybe this therapy will be available for our patients within the next 1 to 2 years. So more to come, but this really represents a completely new and extremely effective therapy for patients with prostate cancer. So the final study that I want to talk about was a small study called the HERO trial, which got a lot of attention at this year's ASCO conference. And the reason is that this trial looked at a new form of what we broadly call androgen deprivation therapy. So, as I started the talk, we talked about the fact that androgen deprivation therapy, basically suppressing testosterone, is still really the bedrock of prostate cancer treatment. It's effective. It often can result in disease control for many years, but unfortunately, we know that patients pay a big price for that. There are a lot of effects. What I want to focus on are the effects on the right side of this slide, which are the metabolic effects. So we know patients who are on long-term androgen deprivation therapy have a myriad of things that happen. There are changes in the body. There are changes in lipid profile. Patients develop insulin resistance, type 2 diabetes, and most importantly, we know that there is an increase in cardiovascular events, cardiovascular morbidity and mortality. And I think what's surprising is that still to this day, the number one cause of death of most patients with prostate cancer is ultimately cardiovascular disease. So there's been knowledge that long-term androgen deprivation therapy is a key part of prostate cancer treatment, but it's very toxic. And there's been a real desire to come up, frankly, with better drugs, better therapies. And so that was really where this trial comes in. So this trial looked at a very new way of treating or suppressing testosterone. And before talking about it, I want to just go over the differences between what we call GnRH, or gonadotrophin releasing hormone agonists, which are what we have traditionally used. So these are medicines like Lupron, which is the most commonly used form of androgen deprivation therapy in prostate cancer. So this is the slide on the left. So essentially, these medicines simulate the GnRH, or gonadotrophin releasing hormone, produced by the hypothalamus. They stimulate the pituitary gland. They increase FSH and LH production, which then increases testosterone production from the testicle and ultimately acts on the prostate through the androgen receptor. So in the case of prostate cancer, testosterone is obviously stimulating tumor growth. The issue with the GnRH agonists is that initially they actually raise testosterone levels, and then with continued use, there's a negative endocrine feedback loop that occurs that ultimately results in testosterone production dropping fairly dramatically. The reason that's important is the drugs don't work immediately. In patients with metastatic disease, there can be something called a testosterone flare, where the disease can get a little worse before it gets better because the testosterone levels go up before they go down. And long-term, patients have increased FSH levels. FSH is another hormone, and the reason that that's important is FSH has been one of the factors that's been implicated in the higher rates of cardiovascular disease in patients with prostate cancer. So relugolix, which is the drug studied in the HERO trial, was a type of a new class of drugs called GnRH antagonists. So these drugs work very differently. They directly antagonize or block the receptor for the gonadotrophin releasing hormone on the pituitary, and immediately lower FSH and LH levels, immediately lower testosterone. So they have a quick and profound effect on testosterone production. So a completely different mechanism of action. So there's been a lot of interest in this newer type of androgen deprivation therapy. So in the HERO trial, patients with advanced prostate cancer were enrolled, and advanced prostate cancer in the trial was broadly defined as either patients who had biochemical relapse, which again means patients who have been treated with traditional prostatectomy or radiation and then have a rise in their PSA, or patients who had newly diagnosed metastatic disease that was sensitive to testosterone, or patients who had advanced local disease that was felt to be incurable. So it was nearly 1,000 patients. It was what's called a 2-to-1 randomization. So what that means is for every one patient that was assigned to the standard arm, which was leuprolide or Lupron, 2 patients were put on the experimental arm with relugolix. And essentially, the primary endpoint was testosterone recovery, and then there were multiple secondary endpoints, which we'll get to. It's important to note that this was an early analysis of the trial. There'll be more data coming out as time goes on, but it was the first endpoint that was examined. And so it was a small proportion of the patients, about 184 patients. So these were patients that after 48 months of therapy were allowed to come off. So these were mainly the patients that did not have metastatic disease. So the first endpoint or primary endpoint of the study was testosterone recovery. And so what was demonstrated was there was a really dramatic difference in testosterone recovery in those patients who came off, the 184 patients who came off after 48 months of therapy. So at 90 days, so meaning 3 months after treatment had been stopped, the mean testosterone value in patients on the relugolix arm was 280, which is in the low range of normal, versus 50 in patients who are on Lupron. So, almost a 5-fold increase in the mean testosterone level. So there was a significant difference in testosterone recovery, which is important because we know not only do patients feel better when testosterone recovers, but it's better for their long-term health. The secondary endpoints were also met. So these were essentially PSA response at day 15, meaning how many patients had a dramatic fall in their PSA 2 weeks into therapy. Virtually 80% of patients receiving the new drug relugolix versus only 20% on Lupron. The probability of testosterone suppression to less than 50 nanograms per deciliter, which is kind of our main goal. 98% of the patients on relugolix versus only 12% on Lupron. And then the probability of what we call profound testosterone suppression, which is really deep testosterone suppression, defined as a level less than 20 nanograms per deciliter, almost 80% of the patients on relugolix versus about 1% on Lupron. And then importantly, the mean FSH level was much lower on relugolix, 1.72 versus 5.95 for Lupron. The reason that's important is we think that persistent elevation of FSH levels may be a risk factor for cardiovascular mortality. So probably the most exciting thing was in this trial was this graph right here. So this was the cumulative incidence of major adverse cardiovascular events. So things like heart attack, which ultimately we really care about, and we want to reduce the frequency of those types of events. And what the trial showed is there was a clear difference between the new drug relugolix and the old drug Lupron. So essentially, on the Lupron arm, the mean adverse cardiovascular event percentage was 5.6%. On Lupron, 2.8, I'm sorry, on relugolix, 2.8%. So a big difference between the two, frankly, bigger than the authors of the trial had initially expected. So in summary, this new drug, relugolix, achieved very rapid testosterone suppression. It was superior to Lupron or Lupron in maintaining testosterone suppression for 48 weeks. There was a much faster recovery in testosterone after the drug was discontinued. And most importantly, there appeared to be a 54%, a large reduction in cardiovascular events with the new drug. So the authors of this trial have concluded that relugolix has the potential to become a new standard of care for testosterone suppression in patients with advanced prostate cancer. But like the other two therapies we discussed, it is also not currently FDA approved. It's hoped that the data from this trial will lead to its approval in the very near future. So in summary, in terms of where we are going forward, there were really what I thought were three very interesting studies at ASCO this year. The new PSMA targeted PET scan, it's a new imaging modality that promises to be more sensitive and more specific for the detection of occult metastatic prostate cancer, especially in patients with low PSA levels. And going back to the beginning of the talk, detecting metastatic disease is increasingly important because there's a lot we can do for it. The second study, probably the most exciting, looked at a new small molecule that's radio-labeled and targets the prostate-specific membrane antigen. It looks to be a completely new and very effective therapy for patients with metastatic prostate cancer who have progressed on our standard treatments. And most importantly, it appears to have very minimal toxicity compared with other therapies. And then finally, relugolix, which is a new oral form of androgen deprivation therapy that appears to be more potent and also with less long-term toxicity than standard therapies. Important to note that none of these therapies are currently FDA approved. There's a lot of research being done. The trials are coming out rapidly, and we hope that these are going to be options we have for patients in the very near future. So that really concludes my talk. So I'll just open up for questions.
All right, Mark, great job, by the way. Wonderful presentation. I think we don't have any questions as of yet, but if any patients or anyone out there has any questions for Dr. Barnett, please feel free to go ahead and type away. So the Lucium data looks very promising, and I'm sure that when we have the follow-up data, it'll, I'm sure, be FDA approved. So as far as Lucium PSMA, it's not FDA approved yet. How's the administration and the requirements for patients? Is it infusional or?
It's infusional. So there's already a model. There are basically Lucium particles that are used, Lucium small molecules that are used in the treatment of other diseases, primarily a disease called a neuroendocrine cancers. It's actually an outpatient treatment. Usually these are done at a specified center because it is a radioactive particle. There's a lot of oversight that's required. It's given intravenously in the outpatient setting. So usually the patient comes in, an IV is placed, they're given the drug, they're observed for a period of time. And in the case of the Lucium PSMA, it's given every 3 weeks, or I'm sorry, every 6 weeks, and can be given for up to a year.
And then the last study you showed when you were looking at testosterone recovery, was there any long-term data about how long men maintained a low PSA? Because it seems like you have a rapid decrease in the PSA, and then the testosterone quickly whips back up.
That data was not presented at ASCO this year. The important thing, I think, is that HERO, the trial is ongoing. So, it really was kind of an analysis of a small subset of patients who were allowed to come off study. The trial is still ongoing. The data is still being collected. So my guess is that at ASCO next year, we would have that kind of data.
So we do have, Mark, one question, and it's from Erica Williams, and she asked, do you know if the PSMA 177 trial is only for those who have been androgen receptor sensitive, or does it include resistance?
It includes resistance. In fact, most of these patients were patients that had androgen resistant disease who were being treated with docetaxel chemotherapy as a result.
Right. And that's probably the biggest, that's the biggest need at the moment. But
right.
you foresee this, being moved up into an androgen sensitive arena. Just much like, as you mentioned in the charted study, really everything's trying to be moved up slowly.
Right. Yeah, I see, hopefully this therapy will be FDA approved in the next couple of years. I think it's going to require a phase 3 study, which is already ongoing, fully accrued, and will hopefully be reported out towards the end of next year. But it would be initially like most of the newer therapies used for patients with androgen resistant disease. So further down the line. But I think what's so exciting about it, is we really haven't had, an enormous amount of new therapies, new ways to treat patients. In the initial slides that I had looking at, more novel treatments, prostate cancer, unlike a lot of cancers, has been kind of a disappointment when it comes to immunotherapy. There was a study looking at Keytruda in patients with what's called MSI high cancer, which means cancers that have a lot of a deficiency of a DNA repair protein. But unlike other cancers, those in prostate cancer, that's only about 3% of patients. So the more novel therapies that have proliferated in other disease types haven't proliferated to the same degree in prostate cancer. PARP inhibitors that treat patients with what's called a BRCA or ATM mutation. So this is a genetic mutation that's either hereditary or arises within the tumor, are also only used in a fairly small percentage of patients, roughly 15% of patients with prostate cancer. So I think the reason that this has been such an exciting trial is this is really a completely new way of treating the disease, something that we've been waiting for a few years now.
Yeah, great. Yeah, that seems to be the most common question I get from men with prostate cancer is, immunotherapy and
right.
And as you said, it unfortunately has been underwhelming. So, this Lucium study looks very promising, and much like, as you mentioned, with neuroendocrine tumors, where it's gained a lot of momentum and there's been a lot of success. Hopefully that'll play out as well for prostate cancer.
Yeah.
Well, Mark, I don't think we have any other questions. And if anyone has any questions, you can feel free to post on Facebook, and we can always get those questions over to Dr. Barnett and respond to it after the fact. But Mark, thank you for presenting. Wonderful job. And thank you for working on your day off.
Oh, no problem. Thanks for having me. It was a joy. It was fun. Great to do it. All right.
Great. Take care.
Yep. Have a great day.